Welcome back to our RHC short series. This is the second in a series of videos where we're going over key concepts related to rural health clinics in shorter form presentations as opposed to our more typical full hour plus long webinar formats. If you have a topic related to RHCs that you'd like us to tackle, definitely let us know. Today, we're going to be looking at the cost per visit, the core calculation on the RHC cost report, and we're going to go ahead and jump into that. As I said, this is the primary calculation taking place on the cost report. The cost per visit is used for rate setting for RHC visits. It goes towards calculating the all-inclusive rate. And it is calculated by dividing allowable costs by RHC visits. That's a pretty simple formula, but we're going to break it down into its components and talk about each one individually. So we're going to start with allowable costs. This larger screenshot that I have over here is the list of cost centers on worksheet A of the cost report. And each of these cost centers can be split into basically three categories. RHC related, which is cost centers 1 through 32, overhead, which is cost centers 40 through 68, and non-RHC related, which is cost centers 75 through 89. The RHC related cost centers are things that are directly related to rural health clinic services. Overhead is going to cover a variety of things that's going to be applicable both to RHC related and non-RHC related services. And then, of course, non-RHC related services are going to be related primarily to things that are not reimbursed on the all-inclusive rate. So that's going to be pharmacy, dental, optometry, telehealth, at least telehealth that is not mental health telehealth, and also chronic care management falls into this category, as well as lab, radiology, and a variety of things that would not be reimbursed on the all-inclusive rate. So once you have your costs separated into these three categories, these different formulas are used in this section of the cost report, which is worksheet B part 2, in order to determine your total allowable costs. And so your total RHC related is added to your non-RHC related costs, and then that gives you what's considered total non-overhead. And then your RHC related costs are divided across that to give you this RHC ratio, which is a estimated percentage of how much of your costs are related to RHC services. That RHC ratio is then multiplied with your total overhead costs to allocate your overhead between RHC related and non-RHC related. So this amount, which would be the overhead applicable to RHC, is then added to what was initially considered RHC related costs to give us an amount of total allowable costs. One major thing to consider here is that your non-RHC related costs is negatively impacting your cost per visit. This is not necessarily a bad thing because, as I mentioned, these services that are incurring non-RHC related costs are often reimbursed through different methodology. You just need to be aware that these costs are negatively impacting your cost per visit. You need to be able to know that whatever reimbursement you're getting from these services is more than making up for any detriment to your cost per visit that's happening based on them being non-RHC related costs. So we'll go ahead and jump into the next component of this calculation, which of course is RHC visits. Now, definitionally, an RHC visit is a medically necessary face-to-face encounter with a physician, physician assistant, or nurse practitioner. Mental health visits with clinical psychologists or clinical social workers also count as RHC visits. And soon this is also going to include visits with licensed professional counselors. And that's going to be starting in January of 2024. When we're looking at RHC visits and attempting to get a number, which is going to be the denominator in our major calculation, we are looking at CPT frequency reports, which are broken down by provider. They have to be broken down by provider because we input them into worksheet B of the cost report based on provider type, and that looks like this. This is what worksheet B looks like. And they are input based on how many visits are seen by a physician, how many visits are seen by physician assistants, how many visits are seen by nurse practitioners, etc. It's also important to note that when we're looking at these, we don't want a frequency report that's broken down based on insurance. Because of the way primary versus secondary insurances work, a lot of times that can end up with visits being double counted, and that's really what we don't want. Because if we're double counting visits, then we are artificially inflating the number of visits that we're counting, And when you have too many visits that are counted, that's driving down your cost per visit. That's not what we want. Now, in talking about avoiding overcounting, I want to take a brief moment and talk about productivity standards. Uh, Productivity standards are certain amounts that CMS has decided that providers should be seeing on a regular basis. So for physicians, this is 4,200 visits per FTE. FTE is full-time equivalent or full-time employee, depending on the situation. Um, so in this case, if you have a full-time physician, which would be 2,080 hours a year, if you have a full-time physician, they should be seeing 4,200 visits. Physician assistants be 2,100 visits per FTE, and the same for nurse practitioners, 2,100 visits per FTE. So your productivity standard is calculated based on the amount of time your providers are working in patient care. So if you have a physician who is working half the time in patient care and half the time in admin, it's very important to keep track of how much time they're spending in each capacity. And let's take a look at this example to show why it's important to accurately track your provider time. These are identical in terms of visit count. So they both total to 6,597 visits. That's 2,236 visits for the physician and 4,361 visits for two nurse practitioners. The only difference is how the physician's time was tracked. So in the first example, the physician's time was not tracked, and we just assume that we have one full-time physician on staff. The cost report sees that they saw 2,236 visits, which is less than the 4,200 productivity standard. And because of that, that higher productivity standard was plugged into the calculation instead. That means we end up with total visits on this report of 8,400, and whatever this clinic's allowable costs are going to be spread across 8,400 visits instead of the counted amount of 6,597. Now, in this same situation, if we're tracking our provider time and we know that our physicians spent half of their time doing administrative duties and only half of their time actually seeing patients, then we can plug in a 0.5 FTE for their patient care time, meaning that their minimum visits for productivity standard purposes is only 2,100. And because this is less than the visit they saw of 2,236, the cost report takes what was counted, and we are able to spread our allowable costs across this 6,597 number as opposed to 8,400 in the other example, which is going to do two things. It's going to more accurately represent what's going on in the clinic, and two, it's going to more favorably impact the clinic's cost per visit. The last thing I want to touch on is the rate cap. Now, the rate cap, it goes up every year. It's the highest possible paid cost per visit for any given year. The reimbursement reconciliation that occurs in the cost report will use the lesser of whatever the calculated rate is, determined based on the formula that we talked about, or the given rate cap for the year. So I have a table right here that shows the RHC payment limit over an 8-year period. Before 2021, the cost per visit cap was at around $85, and it was going up based on the Medicare Economic Index every year. And at that point in time, just about every rural health clinic in the country was operating well over that cap. And because they were all operating over the cap, the actual calculations on the cost report didn't have as much impact on what was actually being reimbursed for RHC visits. Now that this cap is increasing year over year, and it's increasing at $13 per year, which is a very large amount. It's increasing at $13 a year until we get to 2028, where it will be at $190 per visit, at which point it'll go back to going up only based on the Medicare Economic Index. As this rate continues to go up and up and up, it's getting more and more important that the cost report information be as accurate and complete as it possibly can be, because it's going to be very, very soon that most clinics will be operating under the cap, meaning every potential change in cost from year to year will have significant impact on the calculation. because we'll be operating under the cap. So I say that just to say that it's more important than ever uh, that you be aware of how the cost per visit is calculated. That's what we have for today. Check out the RHC Information Exchange Facebook group if you're not already a part of it. It's a great resource. There's lots of people on there who have years and years of experience with rural health clinics who will be more than happy to help answer any kinds of questions you might have about RHC operations for the RHC community. Check out our website, ruralhealthclinic.com. We post all kinds of helpful templates and information. If you haven't already, check out the first video in this series. We talked about Medicare bad debts. And if you're interested in finding out more about cost reporting, check out our playlist on cost reporting. That's all for right now. Thank you.